The chair wishes to thank all of you who came here instead of going to the Taylor Swift concert tonight.
Murph is not going to be here.
He told me. Yeah, he told me. I don't know where Wayne is. I don't know. He would have sat down. Yeah, I know.
In
Oh.
many ways, you were better off at the other committee.
This is a meeting of the Health and Human Services Oversight Committee on Friday, May 19th, 2023. Would the clerk please call the roll?
Representative Pearson.
Here.
Representative McDonald. Representative Weber. Representative King here. Representative Edwards.
Here.
Representative Merchant. Here. Representative Murphy. Senator.
Excused absence.
Excused.
Mhm.
Senator Rosenwald.
Excused absence. They got this thing called a budget.
Oh, all three of them.
Well, I don't know about,
Great.
but Gray is chairman of it.
Senator Gray and
Yeah.
Senator.
Avard, I've not heard anything from him.
Okay.
So, anyway, here we are. Do we have a quorum? Good, thank you. If you haven't seen it already, please take a look at the draft minutes of April.
Checking the numbers because I was told it's half plus one.
Mm-hmm.
Which opens the question, so what? I mean, if do we send everyone home or do we just
We
not
just
take any
kind of
vote?
nod that the minutes look good to us, and I've not been a stickler on that.
Always put them off.
We can, so,
We have exactly half.
okay, who can I swear in?
Chairman, John Williams, if I could just, or not.
You want to be a member for quorum purposes?
Not exactly, Chairman, but what I wanted to bring to your attention, you actually, under statute, have 8 members, so the 4 plus 1 is 5. There are 2 alternates that serve on this committee as well.
Is this your way of saying we have a quorum?
Yes.
take a look, please, at the minutes of the last meeting of,
I would move we accept the minutes of the last meeting.
I'll second
do
that.
we have a second?
Second.
Second, thank you. And I think we have kind of looked at them, some of this that floated by us in email, and I give a minute for anybody to take another look.
May I?
You may.
Okay, so at the very top of the second page, it continues with developmental disabilities and acquired brain disorder, and the bullet is the DD wait list.
Uh-huh.
I think there was a relevant discussion about continuing to expand upon the information shared with this committee relative to the real wait list and not just the funded wait list. We've had reported for quite some time that we fully funded the DD wait list and have a zero, but then we'd like to really start to get into the details of what the reality is about having service providers connecting with clients, and so that's kind of missing in there. And I don't know if it's worth opening the minutes up again, but I don't want to lose track of the fact that we have been requesting details.
I would find that helpful.
And it's no problem opening them back up again. Just wouldn't print them out before the meeting, of course. So, how do you want me to word that? Continuing conversation about fully funded?
I think we could just keep it simple and add a second bullet under DD waitlist. I mean, this is me, it's the chairman's call, but I think it would be adequate to just say that that the committee continues to voice interest in receiving details on the actual wait list.
You could actually say funded positions versus filled positions.
Could you?
Yeah,
Could.
they're different, you
You
could.
might not want to.
No, I don't know
I'd like
if
you to
if it's as clear as it was whether they're funded or filled, but
Well, I said versus.
Yeah.
Because we know what funded is,
Yeah.
but just because we funded them doesn't mean there's a person actually delivering the
Right.
services, because we've got a provider problem.
And that's kind of the rub.
And I thought that was what your point was.
Well, that is a waypoint to where I'm going.
Oh, okay.
Yes, ma'am. I just am also hoping that eventually we get beyond the whether or not we have the case managers working the cases, but to actually get to the provider level. So like, let's say you've got somebody on the DD wait list that needs 5 services, and 2 of them are being met, but the other 3 are not because the humans don't exist in that area. I would hope that we're trying to aggregate that kind of data so that we can get a view. That's really where I'm going. But if you just made that a bullet, I'd be happy to just defer how you write that to you, and we could still approve these minutes with that change, I think. But Representative Weber knows better.
I thought that funded positions versus filled positions in my mind means exactly what you just described it. But however the clerk feels most comfortable is writing it down, because I think we're talking about the same thing.
So I'd like to move that we accept the minutes with the contingent upon the clerk writing and
Trusting the clerk to make sense out of what was just said. And,
Yeah.
all right, any further discussion? All in favor?
Aye.
Opposed?
Aye.
Now, a chill went up my spine recently when I learned that there was, in fact, a standing subcommittee on Alzheimer's disease. It's a bigger title than that is out of this committee. And I've been chairman for 3 years and I never heard of it. And sometimes things go into abeyance and we can always blame either the cat or COVID when something goes wrong. So since then, I've been brought up to speed, and I would just like about, maybe 5 minutes to get before all of us what this special subcommittee is about, the amendment that's been produced, and where we go from there. So we'll start with Representative Edwards.
Thank you, Mr. Chair. I think the thing that stimulated the observation that we were supposed to have this subcommittee and it did not exist was an initiative in HB2 by Senator Avard, working with a couple of lobbyists that are with us today, Tom and Jess, and they have really great last names if I would remember them. But so they have been supporting an initiative to write an HB2 item saying that we wanted to invest $500,000 in the coming budget cycle so that we could develop a public awareness campaign specifically to help with Alzheimer's and other memory-related issues, and to take it through Ms. Hardy's department and in a branch related to Wendy Altman's elderly affairs. I'm not getting the title exactly right, but so this is a new initiative. The department has recognized the need to develop some materials to help the public understand the importance of things like going and getting the Medicare testing, going through the Medicare testing program to start to benchmark and evaluate changes in cognitive abilities and other things. They're $500,000 appropriation, and in their effort to find stakeholders to coordinate this public awareness campaign with, they wanted to interact with the subcommittee that's supposed to be part of this oversight committee, and that's what the chairman is referring to, a subcommittee that has not been appointed in the recent memory. So it would be my recommendation that the chair consider at least doing a partial delegation and reestablishment of this subcommittee, just so that there's at least a connect point for the HB2 item and the stakeholders, so that there's someone to pick up the phone from oversight.
Well, the chairman has actually begun that. And going back to chapter 126-A:15-a, the subcommittee on Alzheimer's disease and other related dementia, we have all of these wonderful people who are supposed to be appointed, and our gal, Miss Eskeland, has been on this and contacting people and making recommendations, and wow. So thank you. Would you folks like to come on up and say a few words, because we've got this chapter 126. I think you all should have one.
Well, and coming up, I will say that I was the immediate past chair before you, and I didn't know about it either. So that gives us 5 years of history.
Wow.
Well, thank you, Mr. Chairman. For the record, my name is Tom Praisall from Demers and Praisall. We represent the Alzheimer's Association.
My name is Jessica Eskeland. I'm the Senior Public Policy Manager for the Alzheimer's Association's New Hampshire chapter. And so this initiative, as was discussed, was brought forward. It was brought to my attention by Tom that this existed in statute, and it seemed, I know that previous legislation had come through that subcommittee that was able to really do a deep dive and take a look at these issues and had come up with some really positive policy in the past. Due to some vacancies and staff turnover in my position, as well as then subsequently COVID, it sounds like, as the chair said, this was sort of held in abeyance. And this is something that we're eager to revive, to look at this issue that's becoming even more prevalent of an issue here in New Hampshire. So happy to be a resource, help organize, as we discussed, in any way that is helpful, but that's really what we're looking to do. And as Representative Edwards said, they are named as a stakeholder in that language in House Bill 2, just to have more oversight, more engagement with the legislature and folks charged with looking at these issues.
I do have a question in that a memo to me of the 22nd of February on Senate Bill 234 FNA, an act directing the Department of Health and Human Services to develop the campaign, and then the aforementioned chaptered law about the subcommittee. Is it true? Does anyone know? Has that Senate Bill 234 been folded into the trailer bill?
It has.
It has. Good.
Yes.
Okay.
So, not in its original version. We had worked with Representative Edwards. I know he had shared language that we had arrived at through discussion with him and with the great folks at HHS to get to language that everyone was comfortable with. So it maintains the original spirit of the bill, but with much more specifics and adding that the appropriation would sunset in 25.
So the program part of it is in the trailer bill, but the establishment of the commission is already in law?
Correct.
So you have been doing due diligence to find these various representatives to fill all these slots.
Yes.
And the chair really appreciates that because I do that job sometimes. And thank you. Also, for our purposes, Pat Long, Representative Pat Long, had chaired this at one point, and I would like to give him first right of refusal. If he'd like to pick this up and run with it, again, he's got the experience. We're not bringing Don LeBrun out of retirement to do it. So I think Representative Edwards would be, Representative Long would be wonderful, and we'll be in touch with him and go from there.
Great.
Anything else before we move on?
I would just say that if for whatever reason Representative Long is not interested in doing it, I'd be happy to be the rep.
You were my second
I've now
choice.
gotten dirty enough with the issue that I would know kind of where we should go.
Well, that's what I thought as soon as you first sent me that draft Senate thing, that, yeah, okay.
Mr. Chairman, if I can just make a quick
Please.
comment about some of the work, the past work that the permanent subcommittee has done. It's developed a state plan for the state for Alzheimer's and dementia training. They worked on creating a silver alert program for if someone wanders or is missing. And they also worked on language to create some dementia training.
Do you have that in your possession somehow?
I can find it's legislation that has come through and passed
If
over the years.
if you've got those documents, it'd be helpful, at least for the chair, to have that in the folder on this. And if it's electronic, you could send it to all of us, and those of us who wish to could read it. It's just a way of getting up to speed.
Absolutely.
Thank you so much. Representative Weber.
There was a great deal of discussion in one term about a bill that was training on dementia for personnel at nursing homes, and my recollection was that the discussion was not so much with respect to the professionals who worked at nursing homes, but having the rest of the personnel understand the different ways that people with dementia need to be related to. And so there was a lot of discussion about whether the grounds people had to be trained or whether the cooks had to be trained. So, but is that the one you?
That was one of the bills that kind of came out of this permanent subcommittee.
And it looks like we have to file legislation by September this fall?
September, there's 1 week in September. Some of us voted for 2, but
So if we could have this sooner, not later, because if there is more legislation that maybe needs to be forthcoming, we want to hit the ground on that by that date. Representative Merchant.
Thank you, Mr. Chair. I think this is a good step going forward. What I find missing is that drug therapy is a significant part of treating Alzheimer's, yet there's no pharmacist on this commission.
So the commission was established back in 2014 when I'm not
Still no
sure.
pharmacist on the commission.
Yeah, well, if you look,
So how would we
legislative period opening up.
put it there? Thank you.
I mean, that's the only way you can
Add it.
change this because it's
Thank you.
a statute.
Yeah.
but as they meet, if you know anyone that would like to participate, obviously it's open to the public and their input would be invaluable.
I may know one.
Mr. Chair.
Representative Edwards.
Since the topic was open on potential legislative future of Section 126A15A, thinking that this hasn't operated in 5 years and the legislature is still functioning, I'd be thinking that we should scale this back or be thinking about eliminating it, but for the fact that it has an apparent task in the near future relative to helping with the particular public awareness campaign. And I'd be thinking more about legislation that would sunset this than to expand it. But
I would suggest to any of us, because we do need to move on, I would suggest that anybody who has any ideas on how to change the law as it exists by adding or taking away, you talk amongst various people who have some history with this, Representative Long, whomever, the associations, and informally talk amongst yourselves, because coming back to September, we don't have much time if we want to do something. Representative King.
I hope this is a really easy one. Can you just spell your names for the minutes?
Sure. My last name is Prasol, Prasol.
S-O-L?
Yep.
Thank you.
And Eskeland is Eskeland.
It was a very easy question.
Thank you.
We also do have another meeting on the fourth Friday of June before we go into summer hiatus. So if people want to be busy and talk amongst themselves, we could put that into the agenda going forward over the summer. We can have a first bite of that. I always call you Representative Williams, and I mean no disrespect. So thank you. Thank you so much. We squozed this one in because it looked sudden and topical. And now we have our monthly time with the commissioner, or time with Lori. And this time we recognize Interim Commissioner Lori Weaver.
Good afternoon. Thank you. A lot of stuff up here.
I know. The desks aren't big enough.
So I thought I would shape my updates for you today around our Mission Zero. Some of you may or may not know that as of this morning, well, it is Mental Health Awareness Month, all month of May, and this morning the department has announced its Mission Zero, which basically is our effort to reduce the ED wait list boarding and bring that number down to zero. The team, the behavioral team at the department, including myself, has been working steadfast over the last several months to really analyze the factors that it would take to do that. And there were three key drivers that I will shape my updates around. And those drivers are the front door issues, their inpatient supply and coordination issues, and backdoor issues. And we may have heard some of these. In terms of the front door issues.
Can you say your second one again?
Sure, inpatient supply and coordination services. And I'll go through each one of them. But in terms of the front door, you've heard me here and others, front door is the most obvious. Where do people go when they're in terms of distress and need that high level of care, needing some designated receiving facility beds, commonly called DRF beds. So we've had a contract with Solution Health. We're going to be building a hospital with a total of 120 DRF beds. That's going to be coming online at the, I think, at end of 25, beginning of 26. We have Dartmouth Health that we've contracted with for 5 additional DRF beds that should come online, I believe, by the end of this calendar year, beginning of next. We have, New Hampshire Hospital has 31 beds offline, but however, Wednesday at council, we have a contract passed to finally begin the renovation of E and F unit as we know it today. E and F unit was significantly impacted by flooding as well, because that's just the way it goes with good luck or bad luck. And so we not only do we have to renovate, we have to mitigate. I was in the facility last week touring, and I was actually quite taken aback by the level of water damage. Needless to say, there's a lot of work to be done there, and it is beginning. So that is great news, and we're looking for that to come online at the end of this calendar year.
Can you spell E and F for us? What is E and F?
E/F. So A, B, C, D, E, we name our units like the letter of the alphabet. Yeah. So EF. Yep, that's an easy one. I can spell that one. So that's how we coordinate them. That's New Hampshire Hospital E and F unit, yes. And there's been a lot of discussion about those beds being offline, and part of it has been this renovation that will finally happen, which is wonderful. bring some beds that will address some of our front door issues. And we are also bringing online services that are called crisis stabilization centers. So those are going to be centers in the community related with our community mental health centers that will basically be places for people to go other than the emergency room. They will see people up to 23 hours. It's not a bed per se, but it is a crisis stabilization where folks can get services, and if they need continued services after that for ED, they can, and then if not, they may need a lesser level of care. So we're really focusing in on the front door, but as we all know, it's not just the front door, it's also the back door. I'm just going to skip to the back door first before I get to inpatient supply. So when we think about all the folks that we have currently, and I'll just talk about New Hampshire Hospital, we have patients there currently today that don't need that level of care, and they have nowhere to go to. So now we have folks that may have stabilized and don't have transitional housing, supportive housing, or step-down care. So the department is focusing on adding traditional transitional housing beds, step-down care, as well as landlord incentives programs. So the department will be focusing on that legislatively, budget-wise. It's going to take us a little bit to do that, but that's where we're putting and focusing the money and the attention to be able to not only take care of the front end, but the back end. There's also the inpatient supply and coordination issues. So as we know today, we have a level of systems of care. So in the children's system of care, we have 5 levels, 1 through 5, and then we have the hospital. Starting next Friday on May 26th, we will have our first level 5 service called the Psychiatric Residential Treatment Facility. That's the PRTF, Psychiatric Residential Treatment Facility. First in New Hampshire. It's pretty groundbreaking. It's pretty exciting. I believe all of you will be invited to that for next week, for next Friday at Hampstead Hospital.
I've seen it.
You've seen it. You may have heard it. You've heard of it. So that's very exciting for us. That's going to be children serving ages 5 to 21. And those will be the kids that maybe don't need that acute level of care and really, maybe struggling to stay in a successfully finished treatment in a lower level of care. So just because you're in 5 doesn't mean you go 4, 3, 2, 1. You could be 5 and step home. You could be 5 and maybe you step down to 4 and then go home. In the event that you're 5 and you need additional, you can be assessed and potentially receive those services right at New Hampshire Hospital for the acute level of care. We are also got a grant from SAMHSA for certified community behavioral health clinics. There'll be 2 pilots this year. If those go well, those will be stood up throughout the state. So that's basically serving populations that have co-occurring issues of substance use disorder as well as mental health issues. In addition to that, we have what we call care coordination. So we're targeting care coordination positions to assist with bed management. So I will share with you that today, as of today, we have 30 people on our wait list. Today we have 25 DRF open beds in the system that are not New Hampshire Hospital beds. So I'll just say that we have 25 open beds that are not New Hampshire Hospital. So this is a real problem. Those beds are in hospitals right now. And if you look at our website, you will be able to see who those facilities are that have open beds. We have 25 beds, 30 people. We could have a wait list of 5 today. So when we talk about Mission Zero, it's really important. I just want to make the point that it takes all of the system to be able to address that.
Representative Weber.
Could I just ask, you are speaking
Mike.
so fast.
Oh, I'm sorry.
You are speaking so fast, and I'm just hoping that maybe you have this written down or notes that you could send to us or,
Sure.
or a handout or something.
Sure.
Just because I can't write this fast, and it's all really interesting information, and I suspect our clerk is probably feeling.
So the good news is that we did a press release. It's on our website, much of what I'm sharing with you right now today, so we can get you that written statement.
If you give
And
us
I
the
will
link, that's
try to
fine.
speak
It's
slower.
just- I don't mind you speaking fast, I just can't write that fast.
Sure,
And
understood.
if the information is elsewhere, my ears are fine. It's just my hand doesn't keep up.
Sure. So the point I want to make when we think about care coordinator positions, it's really somebody at that macro level being able to look at what are all the resources in the system, state and not state, and how are they being utilized. So our care coordination positions, if we're able to get this approved, would be having social workers and RNs being able to do that oversight and then working and calling hospitals and saying we have patients, can we get patients in, and moving patients around so that those beds are being used and people aren't staying in the system longer than they need to.
Representative Edwards.
I'm afraid we may fast forward through an important thing you just said that needs some detail. You said we have 25 DRF beds that are open. We have 30 patients competing for those 25 beds, but there seems to be a problem in getting any of those 30 placed. Did I hear that wrong? Or is there a reason why we can't take those 30 and move some of them to
The
the 20?
department currently has no authority to force any of those hospitals to take patients off of the ED.
So short of force, what is the issue? What's the problem? Why they want to accept patients? We have patients. It sounds like it's win-win. What do you think is the roadblock?
I'm not quite sure exactly what the roadblock is, but it's not a new roadblock. And I think from our perspective, we're looking at it, do we not have good care coordination? I mean, the hospitals report to us what open beds they have. It goes on our website. We ask them to take them. Why the reasons they can't take them, I can't answer that.
Unfortunately, I don't see Paula Minahan either here today. I'm sorry?
Kathy?
Can you answer that? Could you speak to that on behalf of hospitals?
There's a mic at the end of the table if you just want to use that one.
Good afternoon. For the record, Kathy Pizarro-Thunberg, Executive Vice President, New Hampshire Hospital Association.
Could you say your name again slowly for my clerk who listens well and writes well, but may need a little help?
Sure. Kathy with a K. Bizarro, B as in boy, Izarro,
One more time.
Bizarro, and Thunberg, Thunberg. Thank you. Thank you.
And you are with the New Hampshire Hospital Association as what again?
I'm the Executive Vice President.
Exec VP. Okay.
So thank you for the question. Yes, there are hospitals that do have designated receiving facilities throughout the state. They may have some beds that are unfilled because they also have staffing issues, just like New Hampshire Hospital does as well. I need to look at the department's website to understand their definition of open beds, because there is an ability for the hospitals to identify why those beds are not open.
Okay.
I would add that
We
the
could
hospital
have
has the ability, the hospital also fills some of those DRF beds with voluntary patients, which I think sometimes fills the beds as well, not with DRF patients.
That is potentially possible, but that would mean that that bed is not full. So I guess we need to understand from the department's perspective what they consider to be open beds versus available beds. So I would love to have that conversation with the department so we can clear up that distinction.
Sure.
Okay, that's what we do here, is we try to make everybody get along
Absolutely.
well. Okay, good. Good. We'll do that. Thank you so much.
Thank you.
Mr. Chair.
Representative Merchant.
Out of curiosity, in regards to the hospitals with these open beds or available beds, is there certain hospitals that seems to be more prevalent time at the time, or is it sort of random? So I'm trying to get to, are there certain hospitals that are showing up on that calendar, so to speak, time and time again, or is it basically at that point in time sort of a random selection between the hospitals within the state?
Sure, I'd have to go back and analyze that data, look to see if there are ones that were trending a certain way, but not every hospital in the state has DRF beds. We do have certain hospitals that have beds, certain number of beds, and they are supposed to be taking involuntary patients, just like New Hampshire Hospital.
The data would be helpful, thank you.
Yes, thank you.
Representative Edwards.
Okay, thank you. So, Madam Commissioner, I hope that you have a very productive conversation and with the Hospital Association. And if you guys, in the process of talking this through, end up needing some help, please let us know. You could let me know, you could let the chair know. But I think we need an all hands on deck approach, and I think you do too, on getting this ER boarding issue under control. And so we can't help you if we don't know what the problems are. And so we're very open to that. And I would encourage the hospital association to be part of the team. You know, in Afghanistan, we said one team, one fight. Even though we were from all the NATO countries and all the tribes in Afghanistan, we still unified to do one thing. And so the one thing we have to unify to do, I think, is to get this ER boarding thing down to zero. So I just would like us to have that focus. Thank you.
I will completely support that it is an all hands on deck effort. It cannot just be the state. The state can't move nimbly, but it doesn't have the resources. We have to work with all of our partners. So when we look at these positions that I was talking about, the care coordinator positions, they would be doing just that. They would be calling and working with the hospitals and figuring out where are the barriers, where are the pinch points, why aren't these beds getting filled? So it's our intention to be able to put that into place, to have better care coordination, and to be able to have some movement in the system and not have people waiting in EDs. I think we all want the same thing at the end of the day. So I just share that my update in terms of the department puts forth its commitment towards Mission Zero to do its best to reduce ED boarding, but we cannot do it alone. I will just reiterate that. So when we get to things like landlord incentive programs, we are going to need some help legislatively for sure. Transitional housing beds, with the contracts going through. If I could just continue with some of my update in segueing into New Hampshire Hospital, I talked about the renovation. We're also recruitment efforts continue and will intensify. So as we near the end date of the renovation, that we're able to bring beds online as soon as possible. But in addition to New Hampshire Hospital, we also have a forensic hospital that is going to be built on top of, or beside, I should say, New Hampshire Hospital. So that contract just received approval this morning at fiscal for a little bit of extra money because all costs have gone up since we started our bid process. But DAS assures me that the cost difference that has gone up is still within a contingency that's somewhat reasonable compared to other projects. So I remain hopeful that we will now still have enough money to break ground. We have a contractor for construction selected, and that work is about to begin. So that's pretty exciting. It's been a long road to get there. And one other thing is just construction. I know, I think I should get a hard hat for my job here. The site selection for the new Youth Development Center, the evaluation site report was released last month, and some of you may be familiar with that. We compared 3 sites. We had an outside party do the 3 sites. So we looked at things like the size of the site, the ability for shared services, access, utilities, surrounding environment, proximity to population centers, and external services. So out of the 3 that we looked at, Hampstead was the clear winner in terms of points that it came in.
The quality of the neighbors really nailed it.
We did hear that. Yeah, that was an unofficial assessment. So we are currently waiting for the legislatively. There's an impact committee that is required to start. We're waiting for that to start, and we will engage with the town and answer all the questions that we need to.
Let me comment, I was privileged to be at that meeting and with the professionals hired to examine the sites, people from outside the state, this is what they do for a living and so on. And I was very impressed with how thorough they went through evaluating. They didn't just grab something for God knows what reasons. They really did their job well. The only thing we lack is a subway stop outside the building. Transportation is difficult in South Rockingham County. But other than that, yeah, they did a great job.
If you're interested in seeing the report, it is on our website, if you would like to look at that. So I know I've taken up a lot of time with my update today. However, I know you did ask me to bring Director Buxton, and now it's so much that he's his own item. He's not part of my update. So I do want to point out that when Director Buxton comes up, we also have Stephanie Locke, who is our Director of Emergency Preparedness for the department, and she works in public health as part of the Department of Health and Human Services, and is connected to the work that HSEM will be doing. So if you don't have any further questions for
Do
me,
we have any further questions, Representative McDonald?
Yes, thank you, Mr. Chairman, and thank you, Commissioner. I just wanted to clarify, at the beginning, you said mission zero, and the goal was to reduce a certain type of wait list. Was it the New Hampshire hospital bed wait list?
the emergency department wait list.
Okay, thank you.
Representative Edwards?
So I think technically it's not an emergency department wait list. It's the boarding issue within the emergency rooms.
There's all different ways to say it, but yes, you could say
Right.
people say the ED wait list, yes.
I'm easily confused. I just didn't want to misunderstand. So I have two questions, Mr. Chair. One is a big one, one's a little one. So ultimately, who is the one person in charge of Mission Zero? Who is your one accountable leader in the department?
Well, one accountable leader would be me.
But you surely must delegate. You can't do everything yourself.
I
Is
have a
there-
behavioral health team that is on this, that is comprised of our Associate Commissioner Mercer Hen and our Katia Fox and Ellen LaPointe. So Katia Fox is the director of our behavioral health and Ellen LaPointe is the CEO of New Hampshire Hospital. That is the core team working on this.
It's a team, but who's in charge? I'm sorry, I'm being obsessive because I think.
It's not a simple
accountability-
answer for me to say who's in charge. Like, it would depend on what the issue were, who has decision-making authority on that. We all do, but Marissa Hen would be at the helm of that.
Okay, and then this is a detailed question. You probably don't know. You were talking about a new 23-hour crisis stabilization capability, and I'm just curious if part of coordinating that included making sure that we had a billing approach to fund it. Are there any issues with having there be a funding source for the crisis stabilization, the 23?
I believe there is a funding source for that. I think it's a contracted service with the department.
Oh, okay, because
They're part of the CMHC.
It sounded new to me, so I didn't know if there was a billing code, whether it was a contract, or, no money, no mission. So I'm just curious where.
It is a new service that we're rolling out. It's been in the making, development for a while, but they are funded.
Okay, thank you.
Seeing no further questions, thank you for your monthly update.
Thank you.
See you at the party next Friday. And now we do call forward Mr. Robert Buxton and Ms. Stephanie Locke. And this is the kind of pandemic after action report that Representative Edwards encouraged us to hear about. It's always a good idea. I do this in the facility that I'm in charge of. After an event, whether you made a lot of mistakes or you had a great number of successes or somewhere in the middle, review, see what you did, what would you do differently, what would you do the same, where do we go from here, because there will be another crisis coming soon.
Good afternoon, Mr. Chairman and members of the committee. Is that better?
Better, closer the better.
It's being broadcast.
Okay, so good afternoon, Mr. Chairman and members of the committee. Robert Buxton. I have the privilege of being the Director of the Division of Homeland Security and Emergency Management for the state of New Hampshire. I'm also joined today by our new Assistant Director, Megan Hoskins, who's behind me, and she is going to be the project manager for this project. And with me today also is Stephanie Locke.
Good afternoon, Stephanie Locke. I serve as the Bureau Chief or Director of the Department's Bureau of Emergency Preparedness, Response and Recovery, which we affectionately call EPR because the former is very long.
So, Mr. Chairman, I'm happy to report at the March 8th, 2023 meeting, the Executive Council approved a contract with a company named Tidal Basin. Tidal Basin is based out of Alexandria, Virginia. They are a comprehensive all hazards emergency management company focusing on preparedness, response, recovery, and mitigation services. And they have been awarded a contract to conduct a after action review of the state of New Hampshire's COVID-19 response. The document will serve as a record of the state of New Hampshire's story during the COVID-19 pandemic and in regards to the events, processes, including successes and areas of improvement and solutions are a requirement of the RFP. They will focus on the preparedness and response spanning from January 2020 to June 2021. However, there will be a summary of details that are outside of that area. As we're aware, the public health emergency just ended on May 11th, so there'll be a spillover into additional items that they will review. They have proposed and we've accepted a 4-phase approach to this review. And phase 1 is the initiation, and the project will go from May 2023 to June 2024. The second phase of this will be data collection, and this will be interviews, surveys, and documentation review during the period that we discussed. And that will take place from May of 2023 to October 2023. The third phase of the project will be the AAR and improvement planning development. So this will be the spot where they review the data, identify gap analysis, and identify process improvement. And that will take place from September of 2023 to June 2024, with additional interviews and data collection and clarifications taking place. The fourth phase of the project will be presentation and the final after action review and improvement plan to the state of New Hampshire, and that is due in June of 2024. The work is obviously that of a project team, and we have approached the team and inclusive of Homeland Security and Emergency Management, the Department of Health and Human Services, the executive branch, and the National Guard, who is part of the process for implementing and coordinating the response to COVID-19. The project team will meet weekly virtually with Tidal Basin, and they will continue to work and conduct their process throughout the time period. Focuses of preparedness focuses of area that they will dial in on. They will review event planning processes, review plans created prior to the pandemic and how they were utilized or not utilized, response structures and how it impacted the overall event efficiencies, and how the continuity of operations approach to the continually support the response and preparedness portions of the plan. Response focus areas will work in those areas that are highlighted in the slide, with concentration looking at the unified command post and the unified command approach to the incident, communication with both local, state, and private sector partners, the establishment of the supply chain that was so critical to the overall response community, and the community to support public health efforts with the hospitals, nursing homes, schools, and municipal governments. Areas of note will be specifics to looking at the logistical portion of the distribution of.
Excuse me, this could be a brain cramp at the end of a busy week. I'm trying to see how your talk coordinates with the order of the slides.
I'm on the area of notes. If you look at the top of the slide, and I have bullets. I didn't necessarily feel the need to read each slide to you.
No, but I do, and it means I'm skipping all over the place. I'm not paying attention.
Yeah. So if you look at area notes.
Area notes.
Area of notes on slide 7.
Slide 7, unnumbered, okay.
Yeah. So we're looking at the logistical plans surrounding protective clothing, where to find supplies, vaccination distribution, activation and staffing, the logistical problems in moving supplies around the state, and pointing out the efforts regarding staffing the Emergency Operations Center on a 24-hour basis. How the 2-on-1 system worked, working with suppliers, unemployment, and other staff and volunteers to mobilize and address the response. If you look at the goals of the program, next slide, page 8. These are things that we highlighted in the initial kickoff meeting. Make sure the plan is simple, or the report is simple and easy to understand. Make sure it serves as a guide for plans, disasters moving forward. And base the plan in which response is better for next crisis structural processes, and the state's response can be employed again if another crisis is created or happens. The governor was very specific that he wanted to see this after action be a simple process for us to pull off the shelf and implement again in the need of crisis, and serve as a guide moving forward. I'm certainly open to any questions you might have or anything you'd like me to review.
Representative Edwards.
This is something I have a decent amount of background in, similar stuff. And so I'd like to just, if I may, have kind of a little bit of a conversation.
Yeah, take some time without asking for,
Okay, so it sounds like the plan for what you're going to do with this after action is already embedded in a contract that's signed.
Correct.
So I think my reaction to that is that it's disappointing, because I've been asking about this for a year, and not that I have such a high opinion of my experience, but as I look at this, I have some negative reactions. On the areas of note, under logistics, PPE, where to find supplies, this is sort of the classic military problem that we always prepare to fight the last war. This area of note seems to me to be exactly in that vein, that we're expecting the next crisis to look like this crisis. And I think that sort of biases this in a way in which we needed to take a look at some other issues. Like what other issues? I would say under areas of note, and I don't even know why I'm saying this now since this is a contract, but it would be great if there were some flexibility in here, because of the areas of note, I would think that based on what we've learned from the CDC in the past year, we ought to have, and we knew at the time, that we needed to do a better job of vetting and validating the strategic guidance that we were getting from the federal government, and that we needed to vet their top-down guidance internally a little bit. And with that sort of validation of strategy and top-down guidance, we needed to do a much better job of sharing a reality-based set of policy decisions with the public. One of the big disconnects in the whole response that this setup will not touch is the extent to which we're interacting with federal authorities, translating and validating it to New Hampshire, and communicating with our citizens so that they better understand what we're doing to them. To a lot of people, it felt like we were doing something to them instead of with them and for them. And it just feels to me that the areas of note maybe should have picked up on that a little bit. And I know that wasn't in the form of the question, but if I may, I'd like to continue.
let me put something in edgewise, which I think maybe picks up on that. To what degree can this committee meet with the company that has been hired to input to them? Or have they been hired and they're now turned loose?
No, the committee was, the company was hired and contracted with HSEM to conduct this review. I would have to check the RFP to see what the overall engagement with this committee would be. I don't recall from the RFP if there was a direct call out for this group or not. So that would be a follow-up item I'd have to take away.
My follow-up is it doesn't necessarily have to be this group.
Yep.
But this sounds like the same top-down, we know best kind of stuff that has angered a lot of people in the legislature. So I'm just suggesting. Representative Edwards.
So thank you, Mr. Chair. And I'm so sorry. I spent a career in the Army doing this sort of thing. And so I feel like I have some experience here. On the page where you've got response focus areas, there's a compliance and decision-making bubble. And that's kind of what I suggested could be an area of validation of the strategic top-down guidance is the decision-making around that and how those decisions were made. I don't know what the details are in that bubble, but it may be that within the contract that's already in place that bubble could be further developed. And then on the three bubbles that are sort of side by side here on that same page where it goes communications, information sharing, situational awareness, public information, this comes back to the other area of emphasis, which is sharing the reality-based policies that are being developed with the public. I perceive that if a good AAR would reveal that we could do a better job of communicating to the public why we are implementing certain policies and limiting and curtailing certain freedoms so that people understood what was happening and why. And so I would just point out that that there's a significant amount of communication that would be needed, I think, with the legislature, particularly around superseding and establishing emergency orders, because that's a suspension of our form of government when we enter into that sort of emergency authority. And I believe that we really ought to take a serious look in this AAR at how the political body of the state interacted with each other to make sure that the public had their rights preserved and were part of our comprehensive dealing with the crisis. So I would have wanted to have participated in drafting the RFP, or at least put some feedback in there. I'm really concerned that this thing's already been let, and we're going to get an expensive document that creates a new plan, hoping that the past crisis happens exactly like it did so that we can deal with it, rather than building on a set of principles so that we know how to react as an organized society and not just a top-down control structure. And to make that a question. So what do you think of all of that?
So a little bit about me as a person. I did not draft the RFP that is before you today. This is an inherited project. But for those of you that don't know my history, I spent 30 years as a municipal public service employee. So I was a fire chief, emergency management director, and public health officer in a community in the southern part of the state. So I was inheriting all of those things as we were developing the plan and flying the plane as we were building it at the same time. I would tell you, looking at the areas that you pointed out, that was going to be my exact point, that I believe that when you look at the decision-making processes and all those things, that would be an expectation that I would have, that we would be examining how those things got done. So that is, I believe, part of the AAR will be reviewed, is what that decision-making process looked like and how that was developed. So I bring a little bit different of a spin today than may have originally been intended when it was put together. So I hear those things that you're saying.
Representative Weber.
Thank you. And hearing that, I'm somewhat more reassured by the issue of local knowledge. But I think you're hearing some flack and some frustration from this committee about several other projects where there was a company brought in from away who have told us how to do things, and they have had minimal input from the people whose lives are affected by it. And so I kind of wanted to put what I think, to build on what both Representatives Pearson and Edwards are saying, making a plea for local input and for, again, working for, I think one of the things that we're all talking about is buy-in from the community. And that's consulting the community and informing the community and making the community feel that they are a part of the solution, as well as just being told what to do. Because once they understand why they're being asked to do something difficult, my experience of Granite Staters is they rally around and they're magnificent. And, you know, I'm thinking about the people who were making masks and sewing lab coats because we didn't have any. And there we are using 1910 technology for a 20th century problem. So I do hope that it will be communicated very clearly to Tidal Basin that some of the data collection needs to be the experiences of local people and what they were dealing with, and not just the experiences necessarily of agencies.
Yes.
That would be helpful.
Representative Merchant next, and then Representative Edwards. Thank you.
Thank you, Mr. Chair. I looked at the timeline, which is on page 3. What will be the process to provide this committee periodic updates as we go from phase 1, 2, 3, and 4?
Great question, and I'm going to turf that one right over to the Commissioner of DHHS and ask for what the reporting requirement may be.
The commissioner, I think, is left.
I'm sorry. So we would have to work that out with the agency to see what they want for a reporting mechanism moving forward. Through the contract, the phases don't necessarily call for report outs. So we can develop that as we move forward.
Thank you, but that would be in the RFP. What I'm asking is not what's in the RFP, what the department does as far as reporting back to this committee.
Go ahead.
So I'm sitting on this project committee as well, and so I keep the commissioner informed, and I'm happy to work with her to make sure that we have a cadence of updates for this committee throughout the process.
Representative Edwards.
Thank you, Mr. Chair. So since this contract has been signed, there should be something that I've called in the past a statement of work. The section C in the federal government, I don't know what it is in state government, but there's very specific deliverables. Could we get a copy digitally sent to us of what the statement of work is for this contract?
Yeah, absolutely. We can get you a copy of the entire contract and call that out specifically.
No.
You just want that one section?
I want the section that says what the deliverables are.
We can certainly get that to you.
Right. I don't want to go to law school to read the boilerplate. I just want to know what okay. All right. Thank you.
I was one of 30 legislators that spent 4 days. I won't say where, it was in Atlanta. I mean, I won't say what the organization was, but it's based in Atlanta. And we were talked at. And when we finally got a chance to respond, from the most progressive to the most arch-conservative members of the group, we were angry. Not necessarily at some of the decisions that were made in an emergency in real time, but the tin ear. We were angry at the attitude. I don't want to be angry here. I want stakeholders. And I understand it's sometimes difficult to work on a project and have a discussion when you have too many other folks wanting to jump in right away. I get that. I chair things. I know how that feels. But on the other hand, as things are released at the end, I want to say this was a collaborative effort. And while I don't agree with everything here, I agree with the process. I felt listened to. I felt lots of people were listened to. That's what I want to be able to say, as much as I like the conclusions. So.
If I could add one thing.
Please do.
One of the things that we did add during the initial conversation with them was specific to your comment regarding surveying of the local municipalities and getting a survey out at the local level and make sure we have that information coming. So that process to reaching down and getting down to the local level is already underway.
I will say positively that during the pandemic, there was something that was coming down from on high. And I called up, and since I've known that person, I was in Health and Human Services Committee for 6 years, still keep up with that, some of the folks. I picked up the phone, called somebody and said, you don't want to do that. You really don't. And I gave reasons why. And we had a good conversation. And I didn't get everything I wanted, but I got listened to and taken seriously, and not the brush off, and sounds like they were listening, but they weren't. And what came out was responsive. And, that kind of makes me, to some degree, a DHHS groupie. So I want to give that part of it too.
I appreciate that.
You're welcome. Representative Edwards.
Okay, so in terms of stakeholders, I've had an opportunity to observe that civilization is far more fragile than most Americans perceive. And one of the things that happened because of the way we were doing the executive orders and promulgating new restrictions was creating a bottoms up kind of mob attitude. I hate using the word insurrectionist, but there were we fed into this sort of angst and anger, and had the restrictions been more severe or more prolonged, I don't know. I did not like the social chemistry that was taking place that could potentially lead to violence. So what I would ask this AAR to do, and go talk to some other shareholders in those sort of agitator communities, like Rebuild New Hampshire has calmed down quite a bit. There's probably some groups we could get you hooked up with. Go talk to the people who were hostile about what happened, to listen to them on why they got so spun up, so that the next time we do this, we have a little bit of sensitivity to try to build those bridges before somebody's, goes, there's no bridge here. So, so you mentioned municipalities could be potential stakeholders. That's great. But I don't think it's necessary, but not sufficient. I think you need to reach out and get into the communities of hostility and listen to them. So is that possible? Or is your stakeholder sphere already scoped?
I think the local municipalities are the gateway to getting to those groups, to be honest with you. They're going to highlight, you can go and highlight and watch who was participating at the local level, whether it was at a board meeting or school board meeting, and highlight those groups and be able to figure that piece out. So let us take a look at that. I hear the message, I hear the ask, and let's see what we can pull together on that. I think that your message is crystal clear today in regards to what you're looking for stakeholder involvement, and I appreciate that.
Are any of you familiar with the book, The Psychology of Pandemics?
I am not.
Read it, I would suggest. I've read it several times. And as a people watcher, as a people person over the years, that's something I know a little bit about, is different kinds of people reacting in different ways under different stressors. And with a couple of exceptions, the author of this book nailed it in terms of the pandemic. Except it wasn't written during the pandemic. It was written 2 years before. Him analyzing the flu epidemic of 100 years ago, MERS, SARS, all of those, and watching how different people react to authority figures, to presentations of facts, to all kinds of things. And the people in the equation are as important as where the equipment can be found. And I just suggest this because I'm part-time CEO of a medical counseling facility, and we were ready for the pandemic, not only in terms of equipment, but in terms of doing studies of our patients, how they are likely to react when the big one hits, which we knew it was about to. And because we knew them, and because we thought not just about having supplies and cordoning off part of the building and all of those important things we needed to do, but we did a psychological study of our patients. So we were right how they reacted, but we were ready for them. So Psychology of a Pandemic is an excellent read and will inform anything this group does. Did I see Representative Merchant?
Thank you, Mr. Chair. Mr. Buxton, I want to say thank you for what you're doing. It's not an easy task, obviously. But in saying that, one of the things I think a theme here I'm hearing, and I would chime in on this as well, this is well laid out dealing with a process, but one of the key parts of a process is human beings. And I don't see anything here dealing with the psychology of what you're trying to get to, because that is underlying all of this when you get into a pandemic, is trying to understand how the public's going to react to certain things, what kind of information we're going to have to communicate with the public. I just would encourage you folks, I know the RFP has probably been developed and signed, but think about this, you go through the process is how do we engage the public? How do we try to at least understand the public? Because ultimately, at the end of the day, they're the ones that we need to take care of. But a lot of times they don't come along willingly. They have to basically be a lot of education and so forth with it. So somewhere along the way, if you can, in your side notes, put that as a side note, please.
Thank you.
The author of the aforementioned book is Stephen, with a V, Stephen Taylor, and it was published, interestingly, October of 2019, just before. Anyone else?
I just want to apologize. Mr. Chair, I want to apologize to our guests that I'm a little spun up on this issue. It's taken me a year of twisting it, and it just unleashed on you. So I apologize for the bluntness and directness, and it wasn't meant to be accusatory. It's just accumulated frustration syndrome.
I appreciate you. I appreciate your comments, and I don't take it any harm.
30 years of dealing with municipal government, I'm sure, has built up an appropriate thick skin, sir.
Yes, sir.
Good, good. That's what we want. Thank you.
Have a good weekend.
You too.
Mr. Chair, I'm just going to note that I may have to leave
Okay.
a couple minutes early to write at 3.
Okay. Now, developmental services redesign implementation status update with Melissa Hardy and Sandy Feroz.
Like the kings of Egypt.
That's right.
Probably not felt the same way.
I don't know. Do you know any pharaohs?
Good afternoon. I'm Melissa Hardy. I'm the Director for the Division of Long-Term Supports and Services.
I'm Sandy Farrows, Bureau Chief of Bureau of Developmental Services.
Thank you for having us this afternoon to provide a quick update on the retained House Bill 608.
I apologize for saying I'm a groupie, but go ahead.
Oh, no, we like groupies. We'll take you on, no problem. So I wanted to give a little update. I know we presented last month as well for an update, but the biggest thing that's happened between then and now is we've started our cohort work as far as bringing the providers online. So we have 3 cohorts of about 15 providers in each cohort. A leader from BDS is leading one of each of those cohorts. It started today, so we had our kickoff meetings with the 3 cohorts this morning. And so it's really to shepherd providers on a smaller level to come on board with the direct billing process and answer their questions in a small group with targeted folks being available to respond to their questions in real time.
Representative?
So we're talking about the same thing, because I have had real difficulties wrapping my head around what we're saying when we're saying providers. Are we talking about case management services? Are we talking about direct care services? Which sort of providers are we talking about? And if you could equate this with who's doing the providing now and what we're shifting to, that would be very helpful for me.
Sure. So before this time, all of the area agencies were the 10 area agencies in New Hampshire were really our primary contact, who had contracts with providers that provided, it could have been day services, it could be employment services.
With the area agencies.
Right, exactly. So when I'm speaking of providers, we are now in direct contact with those providers that were typically contracted with the area agencies. So that would be those community-based organizations that provide services to folks with developmental disabilities.
Okay, thank you.
Yes. And so we believe that having these smaller cohort groups as we're coming online for July 1st will provide a more one-on-one approach to be able to answer questions that they have and troubleshoot in real time as far as any concerns as it relates to, our information system, billing processes, enrollment status. So we're excited to report that kicked off today based on the enrolled providers that we have. I don't know if there's anything you want to add to that, Sandy?
Mr. Chair.
Representative Merchant, to pick up this point?
Thank you. what I'm hearing, if I understand this correctly, following up on Representative Weber's comment, the agencies were the ones coordinating the care before, so the way it flowed was from the department to the agency to the provider.
Correct. So, yes. So,
So-
the department to the area agency to the provider.
So now we're going from the department directly to the provider.
Yes, and the area agencies are still involved. Some of them are providers as well of these services, and they're still a very relevant role in our whole delivery system as far as intake and eligibility for people on the waiver, providing support to individuals and families with developmental disabilities. But the real change is these providers will be able to directly bill and not contract with the area agencies to provide service.
Thank you.
Please continue.
So we also are excited to have scheduled some more family in-person engagements, not only in person, but we're also going to do virtual sessions to engage individuals and families with disabilities about any concerns or questions that they may have with the 7-1 rollout, but also beyond. So really trying to connect to those people in the community who are actually receiving the services and having that direct dialogue with them. So we're planning some in-person meetings in June. We're also having some online conversations as well as a video that they can watch as far as, you know, what is direct bill and what does that mean to me as a family member or an individual receiving services.
Thank you
You're
for
welcome.
that. Thank you so much.
And that's
Representative Merchant.
So, given the fact that, go back to what we talked about before, on the provider and the change from the agency to direct contracting, if you will, with the provider who's doing the actual care, how is the agency being funded? Because I would make the assumption before, when they're doing the billing, they probably were taking a certain percentage of the billing to support their agency. So are we going to disrupt the agencies because they don't have a funding mechanism to keep themselves afloat?
So we've worked with the area agencies to develop a Medicaid administrative rate for those services, which was funded, and we're waiting for CMS to give us the official stamp of approval on that methodology. But we did take their costs into consideration in building that rate with a rate-setting vendor.
Thank you.
Yes.
Representative Edwards.
So I think to the point that Representative Merchant brings up, or Mershon, that this is an area of concern for the area agencies because they've adapted to a particular business model, and this is a transition to a different kind of business model. And if you love economics, it also interjects a new component. Instead of taking a share of their revenue to help fund their expenses, it's now an administratively developed fee, which gets to be more in a command and control kind of environment instead of a free market. And so whether or not that's going to be adaptable and flexible over time, I think it's just more challenging because you give up sort of the breathing that goes with tying it to revenues. I think the other thing that's going on in the economics of the area agencies that we should know a little bit about is that there are additional requirements for some IT system development. That's not part of your presentation today, but in the one area agencies, full disclosure, I'm on the board of One Sky. So I'm not advocating, I'm just trying to say what I've learned from that. And that is that they're spending like $10,000 a month for their IT systems in order to support the requirements of the department. And that's going to go up to $15,000 a month. So it's a doubling of their expenses. And so there's just a lot of concern out there amongst the area agencies whether or not they're going to be viable. And it may be that some of them need to go away because we don't need 10 in the future if we can direct bill. But that's the challenge I think we're going to face.
Representative McDonald.
Thank you, Mr. Chairman. It's noticed in this week's calendar, but this coming week, the Health and Human Services and Elderly Affairs Committee will be addressing our retained bills, kind of mapping out the strategy, in anticipation of the fall deadline. And this obviously is on the list. So and I've solicited feedback from committee members to see which bills they want to work on. We've got about a dozen. And, we'll be sifting through that and planning our strategy, but it's up very much on our radar screen.
Thank you.
Thank you for your report, and especially thank you for your movement in listening to stakeholders. Again, like with so many things, at least they want to be listened to, and it sounds like you're making some good progress that way. So thank you for that.
Thank you.
Okay.
You guys aren't done though, right?
We are, unless there's something you want to discuss.
Well, I was hoping,
Done.
I was hoping that we could ask our monthly question about the wait list, the real wait list, and what kind of metrics and statistics you can give us on.
Would Representative Jess Edwards like to ask our monthly question of our esteemed guests?
Yes. Do you have any new
So
graphics or data for us?
So we generally do the wait list every quarter. So we did it last month. I don't have any updated statistics for this quarter.
Mr. Chair, Ms. Hardy told me that last month and I forgot. It's a quarterly report. Thank you for reminding me.
She's forgiving you.
You're forgiven, yes.
Okay, good. Thank you.
Thank you.
The chair now recognizes Olivia May, Director of Medicaid Enterprise Development, and Dr. Sarah Finney, Medicaid Dental Director, and Attorney Robert F. Berry, General Counsel and Legislative Liaison, Division of Medicaid Services. Pull up a chair.
You get the whole team today.
You're welcome to sit at the end over there and we'll visually put you together.
This is not because you're a lawyer. It's not voir dire and you failed.
Thank you, Mr. Chairman. For the record, my name is Robert Berry. I'm General Counsel to the Division of Medicaid. We have Dr. Sarah Finney, who's the Medicaid Dental Director, and we have Olivia May, who is the Director of Medicaid Enterprise Development. So we'll begin by speaking about the goings-ons with the new adult dental benefit, and then we'll transition to some updates on SB 263, which you may be aware of.
Can anyone give us a PI?
So yeah, we'll talk about that a little bit. It seems a little odd to tell you guys what's going on with SB 263 because I did watch it yesterday, and I'm sure you're very well aware. But so without further ado, I'll pass it over to Dr. Finney and Director May.
Good afternoon, Chair and committee members. It's nice to see you again. We've had a lot of exciting things going on with the dental benefit. As far as our network goes, we've seen a slow, steady progression of an increase in providers in the network. As of the dashboard from May 10th, we are up to 117 providers at this point. Oh, wow. One of our priorities is to improve access for geographic regions that have limited provider supply, and doing this through the use of mobile dental clinics. That is one of the key strategies for supporting access in the identified regions. These clinics have been ongoing since April 1st. There have been second visits to both Colebrook and Concord that were very successful. Not only did they have reappointments with folks that were seen on April 1st, but they also were able to see some additional members on the second visits.
And basically, the way that we're looking at moving forward is watching our network adequacy across the state and making decisions about where those mobile events will happen based on where we have areas that have true need. And we're having more difficulty providing access with providers in that area, just because there aren't any. In terms of contract management.
Yes, excuse me, yes,
sorry.
Representative Weber.
Could you be a little more specific about specifically where those areas are? Because if I'm hearing that a mobile clinic is going to Concord, I don't think of it as being a particularly rural or underserved area. And I know we got into this last time about whether Washington was an urban area or not. Right. But I just want to know where it is that you're looking at needing to fill in services so we know.
It's actually a combination of the number of providers and the number of members that are residing in a certain area. There's also certain locations that lend themselves to doing a mobile service. So Concord is a central location, and the facility that we had available allowed us to not only have the mobile van itself, but an area to greet the members, determine eligibility, and then move them on to services. So it's not one single criteria that we have for making that decision. There's many different pieces that go into the decision of where the clinics go.
So am I understanding that part of what the mobile centers are doing is signing up people, not just providing direct services? Is that correct?
It's not that they're signing up members. It's that, eligibility has to be confirmed the day of the appointment. And so you need to have an area where that can be done with privacy. And so, there's a facility piece of this beside just the mobile van itself.
Okay, thank you.
One would think that a rural area would have a lot of privacy.
Mr. Chair.
Representative Edwards.
My comment or question is really very related to what Representative Weber just said, and that is that my issue has been that in Division 3, we had these nice New Hampshire maps presented to us with the demographics of the state, and that there were like 5 hot pockets of where we had disproportionate diversity issues in 5 particular areas. And so I am just trying to map what you all tell me you're doing with what the effect on the ground is. I want to know that we are proactively monitoring these traditionally underserved communities and that we're explicitly trying to resolve those.
So we are working on developing maps to visualize exactly what you describe, what the access looks like in every region of the state. We do have that information from Northeast Delta Dental and DentaQuest, but it's just not at this time in a format we felt was ready to present to this audience. But we anticipate having that in future meetings.
So Representative Weber hit me upside the head with a common sense stick last time, and she said we don't necessarily need a heat map like what I want. We could just take a list of zip codes in an Excel file or something so that we could at least begin to communicate with our colleagues that may be interested in whether or not their community is being served. So maybe as a first step prior to this glorious heat map thing that I want, that we could do an interim basic data swap.
We can absolutely do that. And I'll say too that leading up to April 1st, we had a really strong focus on certain aspects of network adequacy, including oral surgeons. And we saw a lot of success on that service type growth there. And now we are shifting to look more at geographic areas of need. Not that we weren't looking at them before, but that's really become priority.
I think the other thing that I would like to mention is that yes, there are definitely certain areas of the state that for a long period of time have been underserved, and we are aware of them. We're also watching how the membership is changing now that we are past the PHE and we're into what we refer to as the unwind. So there are some changing demographics with our members at the same time that we're watching our provider network grow. So, you know, we're trying to make these decisions, but also keeping those two things in mind as we're moving towards those decisions.
Just to wrap that
Follow up.
just to wrap that up, that's great. I suspect you're really doing the right thing. I'm just asking for you to take us on the ride with you so that we can understand exactly what's going on and that we can communicate. There are 400 of us in theory all around the state, and it'd be great if we knew what was going on in our communities. And so I hope to share what you're doing with them as soon as we get the right data.
That would be terrific. I would love to have 400 recruiters across the state.
Representative King.
Yeah, so a lot of this sounded familiar from the last meeting, and I'm not going to say this is why Mr. Littman didn't show up today, but he did.
We gave him the month off.
He said he was going to provide an Excel spreadsheet with towns.
That's right.
So, yeah, you still got time.
So we can follow up on that to get that to the committee.
Mr. Chair.
If we're, I'm sorry.
Take another bite, as it were. I'm sorry? Yeah, I know. All right. All right. He is one of my two favorite pharmacists in the House of Representatives, so I cannot ignore him. Representative.
Thank you, Mr. Chair.
Representative Merchant, one of each.
Would you, somewhere along the way, to help me understand, maybe the rest of the committee as well, as we go through the Medicaid recertification, how this is going to impact this program? What I'm really concerned about is children, because this is what it's, I mean, it's adults as well as children, but if we're going through recertification, is it going to have a bigger impact on the dental program versus the medical program, or are they basically independent of each other? Therefore, what happens on the medical side really doesn't impact the dental side and the other way around.
All right, there's two parts to my answer. The children's benefit remains unchanged and is as it has been in the past. I think the same impact would be felt for both medical and dental because you have to be fully Medicaid eligible to have either or both. So it would move along the same way.
So do we have some initial data? I think when Ms. Lippman was here before talking about the number of people covered by Medicaid that possibly could be coming off the rolls because of recertification. Are we having any kind of information on the dental side as well as the medical side comparable?
So are you asking for updates on the results of the unwind? So folks who are being redetermined for their Medicaid eligibility and what impact that has on enrollment?
Yes, you said it very well. Thank you.
Do we want to share updates on that? I mean, we can speak to it at a high level that's starting in April. Or go ahead, Rob.
So I'm prepared to provide the Granite Advantage numbers. We do have access to the other numbers that we can absolutely provide after this meeting. But for Granite Advantage, since the unwind began or continuous coverage ended back on April 1st, as of 5/15/23, so a few days ago, the Granite Advantage enrollment was 75,178 individuals. And that's a net decrease of 21,337 since the continuous coverage period ended on April 1st. That's for Granite Advantage. We do have numbers for the others, but I don't have those available at the moment, but we can get them pretty easy.
Thank you. Thank you.
And just in case it's not totally clear, so if someone loses Medicaid eligibility, they have their medical, I like to think of the ID cards, they have the medical ID card, they have their dental benefit ID card. If you don't have Medicaid anymore, you don't have either of those benefits anymore. So it would impact them kind of equally in that way.
And part of the concern with the adults is that when you have a dental issue, a lot of times it's multiple procedures that are being done. So what I'm concerned is that we have individuals who started in the program become disqualified for the reasons for unwinding, if you will, and then all of a sudden they lose the benefit. And I'm trying to figure out at this point in time, do we have any people out there that may fall into that gap where all of a sudden they have it one day, but they're not going to have it the next day? And what that impact will
Absolutely.
look
Yeah,
like.
I think that is something we also talk about with Northeast Delta Dental and DentaQuest. Our 3 medical MCOs are a bit more mature at this point in dealing with the unwind and supporting their members, but that's something we definitely want to see from the dental vendor as well to prevent avoidable disruption in service, as you mentioned.
Okay, please continue.
Move on to contract management. While CMS did approve the contract, they had asked for us to do an amendment, which will occur this fall. And really what they asked for in that amendment is to clean up a lot of language to make sure that our language matches with the current managed care requirements that CMS has. There was nothing operational about the contract that was an issue, so it really would be looked at as cleanup. And so we will embark on that in the fall. In terms of implementation, ID cards and member materials have been distributed. In the initial weeks of the program, operations have run smoothly. We've had some small blips, which anyone might, expect with a program this large going up as quickly as it did, but everything has been dealt with by Northeast Delta and DentaQuest in a quick and efficient manner to make sure that operations continue. The department meets multiple times each week with Northeast Delta and DentaQuest, and we address things as they come up. And I see that those meetings will probably go on for the near future because we want to make sure that we stay on top of the processes and make sure that everything is running smoothly. And then, we've already discussed heat maps versus Excel spreadsheets, and we will absolutely continue to update you and, take your feedback on what best serves your needs to understand our networking.
I'd like to know a little bit about how big Northeast Delta Dentist is compared to DentaQuest in terms of your providers. I think 117 you said right now?
Right.
Roughly.
I'm not sure I understand your question.
Well, I think dentistry in New Hampshire, I think Northeast Delta, because that's what I know, and they gave me a free meal. And I don't know DentaQuest, they're probably good, and I'm sure I'll go out if they invite me. But those two groups do what?
Okay, now I understand.
Okay, I do too. I was getting there.
Okay. Northeast Delta Dental really has the deep knowledge of the New Hampshire dentist network. And in their commercial plans, they are represented extremely well. I believe one of their commercial plans, they have upwards of 85% of New Hampshire dentists enrolled. In their PPO program, I think they're somewhere around 50%. So the reason that Delta was interested in this contract is because of their knowledge of dentists in the state. The reason they subcontracted with DentaQuest is that DentaQuest runs dental Medicaid programs in approximately 30 states across the country. They are the largest Medicaid administrator in dentistry out there right now. And so Delta felt that the combination of the Delta experience to date in state added together with DentaQuest's experience running Medicaid programs made for a good partnership.
So it's collaborative.
Yes.
I could not see the leader of Delta Dental being a ruffian.
And what Olivia just pointed out, it's one network. It's not like these two entities each have their own. It is one single network.
Group. Okay. Thank you.
You're welcome.
Representative Ed.
This is one of my favorite
You are
topics.
on a roll.
One of my favorite dentists Probably because you've never drilled me, so. Hey, I think you meant to imply it, but I just need to hear it. In this contract rewrite, none of that's affecting our waivers. Our waivers are secure.
No.
The policy is secure.
Policy is secure, waivers are secure. This truly is little tweaks
Okay,
of language.
I just had to hear it. All right. And then the second thing, are we starting to get any data on the number of no-show appointments? Because that was a concern with this population. And there was some brainstorming that was to take place, that probably did take place, on how to mitigate the no-shows under the perception that this is a community that no-shows more frequently than other communities. And so what can you tell us about no-shows and what we're doing, and is it a problem, and the like?
Okay, the process that is in place is that through the claims adjudication, missed appointments and late cancellations go through that adjudication, and then a flag goes out to the care management team, and calls are actually placed to those members to say, we noticed that you missed an appointment. We need to talk to you so that we can work out, why you weren't there. So there is a whole process for that is in place. We're only at May 19th, so I really don't have any data that I can share, or have even had the opportunity to look at to see what the rates of no-shows and late cancellations is. But that is definitely something that we're watching.
Representative Merchant.
Thank you, Mr. Chair. That's definitely something I'd like to keep our eye on, because on the provider side, if they don't have a patient in the chair, there's no revenue for that time. And my concern is if this, back to Representative Edwards' comment, this community has probably a higher no-show rate than the normal community. And I'm really concerned about the dental providers out there, if they're having a high incident of no-shows, what that means to them on their bottom line, given the fact that most likely the reimbursement rates from Medicaid are less than what they come from Delta Dental from commercial side. Right. So I'm really concerned about this issue of no-show and what that will mean, because if we don't find a way either to backfill it financially or work with the providers to minimize that, I think we could have providers pulling out of the service, and it's a really concern.
What I would like to add is that we also have a transportation piece of this contract, where if members, through the risk assessment that happens, as they become enrolled with DentaQuest, if transportation issues are identified as something that could potentially create a problem, they are also responsible for providing transportation or mileage reimbursement. So, and the transportation and the care management really came about as a response to our work group, where providers were talking about what are the things that we need to have in a benefit that would make us want to enroll and then also stay in the program. And it wasn't just reimbursement, it was the no-shows and transportation and care management.
Follow up, Representative.
Thank you, Mr. Chair. I want to say thank you for the transportation to try to solve some of that issue. However, when I look at some of the rural parts of the state, it's hard to get transportation. It's a real issue for patients, even in medical care. So again, back to the same thing, if I understand this correctly, not looking for the heat map, but looking at the zip codes, if in the rural parts of our state we're having low provider participation, that's only going to be more critical that we have a way to get them to the dental clinic. And I do concern myself when you get to some of these small towns, even how we're going to get them to point A to point B from the home, if you will, to the dental clinic. And that's, again, back to the underlying issue of what that means to the provider.
Right. And that also ties back to where we decide to take mobile clinics in the future. That is another part of that decision.
I heard you speak of the providers work group prior to the rollout to identify things. Is there a provider work group that's going to meet periodically to assess? Let's say we've been doing this for a while now. let's talk about it.
There are actually two different venues for that to happen. Prior to us even going down this adventure with the adult benefit, we have had a dental Medicaid advisory committee that was a joint function of DHHS and the New Hampshire Dental Society. We are in full swing. We have actually gone from quarterly meetings to monthly meetings, just so that we can keep on top of, provider issues and commentary and helping us to assess what is going on. And then built into the contract with DentaQuest and Northeast Delta Dental, there is a provider advisory committee, and I know that they are in the process of putting together who from their provider network will be included in that. So we have two different processes for providers to be giving feedback and keeping an eye on things.
Representative Edwards.
Just two thoughts. I don't know if you have a response to these two thoughts, but one, on that Excel sheet that we're looking for, I think if it were just the zip codes of where you do have a provider, rather than zip codes where all the zip codes, whether you have a provider or not, I think it's just the zip codes that where you have a provider that would do my purposes. Okay. And then on the other, I don't know where we are with the implementation of the closed loop referral system. And so as I'm just trying to tie a couple of weird puzzle pieces together, I'm just wondering with this no-show issue, if that closed loop referral system might be a nice tool to help you manage that.
Yeah, that's a really interesting connection to point out. I know that the closed loop referral system is not up and running, and I actually don't have today an update on when we might expect it to be in effect, but you're absolutely right that I think we would want that to mesh appropriately with the dental services our enrollees are accessing.
Anyone else? Counselor?
Thank you, Mr. Chairman.
You can make your closing.
Well, I get the sense I might be the thing standing between you and a weekend, so I'll try to be pretty brief. Obviously, I'm going to speak on behalf of the department's perspective of SB 263. I'm not going to tell you how you feel about 263. So the department's view of the status of SB 263 is that it's pretty clear that there's a consensus that some form of the program needs to continue on. The debate, of course, is centered around the duration of the program. The community engagement requirements came up quite a bit yesterday. And it looked like there was a little bit of sprinkling of funding in there as well towards the end. So obviously it's moved on to the fiscal committee.
Unamended.
Unamended. I counted 27 amendments as well.
You too.
Those of us who did the spreadsheet counted 32 and 29 were offered.
Oh, okay.
And just to be clear, it's the finance committee, not the fiscal committee, that it's working with at the moment.
Apologies. I realized that after I said it, I misspoke, but thank you for the correction. So the department will obviously continue to work with the finance committee and be a resource to this body as it moves through the deliberative process on where this program is going to go in the future. And I'm happy to take any questions at this point. How was that good, huh?
You're allocuting that you stand between us and our weekend.
I will just add that, I mean, it all comes down in the end to the Committee of Conference and what the Committee of Conference does. I mean, the House has a position both on the healthcare policy. The House has a current position on the budget, and the Senate has a position which aligns with the House health care policy, but not everybody in the House agrees with it. So the Committee of Conference process is going to be a very interesting one in this case.
I would agree with that, and we're
and that's where it's all going to happen. It irritates me as one of the policy committees that we work on good policy all year long, and then all of a sudden, people vanish into a back room and emerge a week later with either white smoke or black smoke, and
All division,
something that has things hidden in it that I find 3 months later.
all Division 3 meetings are open and noticed.
I understand that, but the committee of conference process is slightly different from that, so.
Just remember where you're an alumnus of Health and Human Services. Yes. Wow. Okay. Our next meeting is the fourth Friday of June, which is June 23, 10 a.m. And please convey our regards to Mr. Lippman. We're done.